And Maya can stop sharing now. So I'll just start with a few words in Hebrew and then we will continue to the webinar in English. שלום, ערב טוב, חברות, חברים. ברוכים הבאים לוובינר של המרכז לבריאות הנפש שלוותה והחברה לבריאות הנפש בקהילה בהסתדרות הרפואית. היום אנחנו מתחילים שיחה ראשונה מבין 3 הרצאות מקוונות ללא עלות בנושא טריאז' וטיפול בהפרעות שינה הקשורות לטראומה עם דוקטור ברי קרקוב. כלל ההרצאות יהיו באנגלית, יוקלטו ויעלו לדף הפייסבוק והיוטיוב של החברה לבריאות הנפש בקהילה, שתהיה לכולנו למידה פורה ומפרה, ומפה נעבור לאנגלית כדי להיות מנומסים. So, good evening and welcome to a joint webinar of Shalvata Mental Health Center and the Israeli Society for Community Mental Health, the ISCMH, which is part of the Israeli Medical Association. For those of you who do not know the ISCMH, we aim to improve the level of mental health treatment delivered in community settings, ambulatory treatment. We have a network of over 600 members who are mental health experts of different fields of specialization: psychiatry, psychology, social work, psychiatric nursing, art therapy, among others. On October 7th, the Israeli population went through a mass-scale trauma, which is considered the 3rd deadliest terror attack after 9/11 and the Tikrit attack in Iraq. Following the attack, over 200,000 civilians had to evacuate their homes, becoming internally displaced persons. And ever since the war, Operation Iron Swords has been going on for almost 80 days now, all of which have extreme mental health implications. According to some research, the level of anxiety, depression, and PTSD among the Israeli general population has increased, and maybe the most notable symptoms are sleep disorders and nightmares. This is why our community of mental health providers should now focus on improving skills, specifically in an area so many clinicians feel they cannot intervene and, let's say, frankly, quite lost, which is PTSD-related sleep disorders. And this is the reason we meet tonight. We're honored to have with us Dr. Barry Krakow. Dr. Krakow is an internal medicine physician and clinical sleep medicine specialist in practice and research for over 30 years. His focus on sleep and mental health led to multiple discoveries to diagnose and treat sleep disorders. He lectures and writes widely on sleep and mental health with over 100 peer-reviewed scientific publications, as well as 4 books, the most recent, Life-Saving Sleep, New Horizon in Mental Health Treatment. To disseminate his sleep quality model of care, Dr. Krakow currently trains psychiatry residents how to treat sleep disorders without drugs using IRT, imagery rehearsal therapy for nightmares, new variations of cognitive behavioral therapy for insomnia, and highly advanced physiological interventions to overcome sleep fragmentation. Dr. Krakow has a special interest in PTSD-related sleep disorders, which makes him the best person to teach us how to deal with the unbelievably common sleep disorders we are now seeing with our patients and with many of us here, the therapists. Once Aviv, Dr. Segev, contacted Dr. Krakow, he immediately and generously accepted our invitation to talk with us tonight. So today I'm joined with 2 hosts, Dr. Aviv Segev, a senior psychiatrist who is heading the service for psychotic disorder at Shalvata, and Lior Biran, a clinical psychologist at our center. I'm Ido, I'm the chair of the Israeli Society Community for Mental Health. And I must say, Dr. Segev, this was his idea and initiative, and he just contacted Dr. Krakow, and here we are. So the webinar will be recorded and available in our Facebook and YouTube pages. And we do apologize in advance if there is a siren going off. At least the 3 of us, Aviv, Lior, and I, we have to go to a shelter. But Barry will stay with you with Maya. I hope we will have a quiet night and we will be able to have a fruitful and educational evening. And as Barry's saying, it's going to be a very sleep-inducing lecture. So thank you, Barry, and the stage is yours.
Let's see now, is this coming up properly? Good?
Yes.
Okay. Let's see. Dr. Larry, thank you for that introduction. Appreciate that. Let me get my slides moving here. Okay. We want to build a cornerstone to achieve a clear understanding of what we're trying to do for patients who need help with sleep problems. And a very good way to consider this cornerstone is to look at the titles, and I'm going to read them for you. These are two presentations that are going to be delivered next year at the annual sleep conference. You see below there's a large group of researchers that participated. We've been working on this project for many years under the direction of Dr. Bernert at Stanford University Sleep Disorder Center. The first study is a non-pharmacological insomnia treatment for suicidal behavior in high-risk civilians. The second one is a non-pharmacological insomnia treatment for military suicide behaviors, a randomized controlled trial. Now, in both of these studies, suicidal behavior, suicidal ideation, was decreased by doing something to the individual's sleep. And they got a bucket full of sleep treatments. They got CBTI for insomnia, they got IRT for nightmares, and they got something called social rhythms therapy, which in some ways is an advanced variation of sleep hygiene. So the question I put before you would be, why would these things work? Why would these things decrease suicide? Because if they can decrease suicidal behaviors and ideation, then we'd expect them to also decrease other aspects of psychiatric distress. And the answer comes in two forms. If you look on the right side first about why we sleep, we know that people need to disengage. They need a respite, a relief, escape, whatever you want to call it. There's a key psychological aspect of how people approach their sleep problems. They simply cannot handle reality. They are exhausted. They are irritated. They're antagonized. They're close to psychotic. They're suicidal. They need this break from reality. And so that's obviously one thing that happened in this treatment of these patients. But on the other side, it says sleep to heal. And this is actually the much larger component of sleep, widely underrecognized or misunderstood in most healthcare professions, including mental health, but really across the board, because sleep actually has the power to heal. Now we have 3 sessions. This one is going to focus on insomnia, the next one on nightmares, the third one on sleep quality. We'll be getting into all these concepts here and there, plus I try to gauge these didactic portions to be no more than an hour, hopefully less. And then we have at least a half an hour for Q&A. And Q&A is a very good time to actually get more involved in answers to some of the pressing questions. Okay, who are we treating? Including yourselves, of course, because some of you no doubt have your own sleep issues. Generally, there are normal sleepers who used to be normal sleepers, no past issues, and now they have trouble. There are troubled sleepers who had a great response to their previous regimen. That regimen could have been psychotropic medications, sedatives, psychotherapy, CPAP, medications for restless legs and leg jerks, all of the above. The last group is, of course, the most difficult, and the ones you will have the most difficult time treating their sleep disorders, where they've had these chronic problems, yet they've never gotten good results, whether it's because the medications didn't work, or a CPAP didn't work, or they couldn't resolve their nightmares and insomnia. Whatever the reasons are, these people now obviously are going to have things happen to them and make it amplified. All of this must be stated in the context of the 2 caveats. You have different types of trauma, different types of severity. You could have somebody who was a normal sleeper who has horrendous trauma type, and other exposures such as the loss of loved ones. And this is going to end up creating somebody who could move into another category. But in general, when you talk to patients, you want to clarify this from the get-go, because it will help you a lot to tease apart what they already have done for their sleep or whether they've done nothing for their sleep. And again, these caveats will play a role to produce what's called personally tailored healthcare, personally tailored medicine. This is the wave of the future in healthcare and certainly the wave of the future in sleep medicine. So what is the problem? Well, the problem we're dealing with today is people saying, I can't sleep. And what's interesting about that problem is it shows up in a lot of different ways. You can have trouble falling asleep at bedtime, trouble going back to sleep in the middle of the night, have trouble going back to sleep in early morning awakening. And so that looks like it's really two problems, like, well, I can sleep sometimes, but I can't stay asleep. But really, it's actually one problem. And the simplest explanation for all of this, because it's so strongly biologically built into our mind and bodies, is the absence of sleepiness. When sleepiness is not there, when you cannot recruit sleepiness, nobody can fall asleep. So that means when someone tells you, well, I can fall asleep, but when I go 3 hours, I'm done, I wake up. Okay, we'll get back to the fact that sometimes 3 hours is all you should be getting, because there are circumstances that say, well, that's it, 3 hours, that's all you're going to get. But if you wanted to go back to sleep, your problem is the same thing. You cannot fall asleep due to the absence of sleepiness. And everybody who's listening, I believe, can relate to the fact that there have been times in your life where you have awakened during the night, rolled over, and went right back to sleep. And that means that you were experiencing the natural sleepiness that should be still there during the middle of the night, and that's why you went back to sleep. So what happened to the sleepiness? Well, I think you all already know the answer to this. Staying awake is the best survival mechanism you can have. Insomnia clearly helps you keep your guard up, and slumber obviously increases your vulnerability. So the mind and the body are very intelligent. They know how to protect you, and they're saying, don't sleep. Where exactly did the sleepiness go? So for some people, it's hiding. It's hiding in ways that make it easy to find, and other people, it makes it very difficult to find. The most common thing to understand about this process is that when somebody is sitting across from you and talking to you about they're tired, they're fatigued, they're exhausted, and you can fill in the blanks of all the other symptoms that sound like this anhedonic, low energy state, that state is often corrupted sleepiness. Corrupted sleepiness. The person really is sleepy, but they can't experience it. They can't feel it for some reason, having to do with hyperarousal, which of course the hyperarousal helps them maintain alertness and wakefulness beyond normal, because that's what they want. They know that's the smart way to be protected. Stay alert, stay awake. So does this mean that a sleeping pill could be the answer for most or a lot of people? Well, certainly suicidal patients can clearly benefit from sleep medication. Any individual who is desperate for sleep clearly needs medication. In fact, let me give you this quick pearl if you don't know it already. We have a phrase in sleep medicine called losing sleep over losing sleep. I don't know how that translates into Hebrew, but losing sleep over losing sleep, when you spot it, it's a patient who is so obsessed with their loss of sleep, they can't even focus on the trauma. They can only focus on the fact that they're not sleeping. That's absolutely a risk for suicidal ideation and behavior at some point, if that's permitted to last. And then last, somebody who must function for whatever reasons, whether it's family, work, whatever the reasons are. If they're suffering a rapid deterioration from sleep loss, sleep medications certainly should be considered. But here's the problem chronically with the great sleep aid caveat, as we call it. And let's go back to the main problem. It's sleepiness, right? But sleep aids do not teach an individual how to feel sleepy. And that's a very interesting thing in that most chronic insomnia users, chronic hypnotic users, actually lose the ability to know what it even means to be sleepy. And this is so bad that if they miss out on their medication or they stop cold turkey or they forget it, whatever happens, they can actually have 24 to 36 hours of insomnia, which again can drive them to quite a state of desperation, ending up in an emergency room. And so it's not a surprise that dependency is going to arise in someone like this, because they equate, well, to sleep, I would take a pill. They're not having this discussion in their mind, oh, am I sleepy? They're saying, take a pill, go to sleep. In the third webinar, we'll talk about some impact of sleep medications on sleep architecture that are very relevant to recovery, or potentially relevant to recovery from trauma. Okay. So the rest of this seminar is going to try to give you the tools where you're going to be able to have discussions with people to get them to recruit sleepiness. And there's a bunch of tools we're going to go over, but none as important as this first one. This is the single most important thing I can say in this session today, that you're going to meet hundreds or thousands of people that do not get the difference between sleepy and tiredness. Let's take a step back and talk about pre-October 7th. When you've been dealing with chronic insomniacs, which I'm sure you deal with, if you have this discussion with them, 90 to 99% of them, when asked the question, tell me the difference, will say, there's no difference. I just get into bed and I go to sleep because I take a pill, or get into bed and I try to go to sleep. And so that's telling you they have in their consciousness the idea that whatever they feel, whatever that is they feel, has no essential bearing on when they're going to actually get into bed and go to sleep. And that's a big deal here if you're trying to help somebody with insomnia. Let me also put in another caveat about, I know we are talking less than 3 months out from October 7th. I know we're talking about ongoing trauma, unending grieving for many people. So I'm not talking about this as if you snap your fingers and you make somebody sleepy. But I am talking about, if you build this framework into the consciousness of a patient who has this problem, even if you have to repeat it at 1 session, 2 sessions, 3 sessions, and so on, you will find eventually they go, oh, I get it. I now see how my mind and how my body works. And I've been getting into bed when I'm tired. And you go, that's it. Now you understand a huge component of how you solve the insomnia problem. And that means that you are engaging this individual to realize that you really do not get into bed by the clock. You do not get into the bed because you're tired. You may have other circumstances that make you get into bed. You may be exhausted and wiped out and say, I need to rest. I'm getting into bed. That's, again, we are not even 3 months out. There's all kinds of reasons people will get into bed. But over the long haul, people who learn to not get in bed when they're tired, but instead get in bed when they are sleepy, those individuals are going to have tremendous success. And that means one of the most challenging steps facing all people with this problem of insomnia, whether it's the 3 groups I described or those listening to this program. If you remain in bed because you think that by remaining in bed, you're going to get more sleep, but you're really not sleepy and you're really only tired, the act of staying frozen to your mattress will now make your insomnia worse for a very simple reason. Your body now believes the bed is the place to lie awake and not sleep. And so it's challenging for the obvious reason. Who the heck wants to get up after 2 hours of sleep, after 3 hours of sleep, again, given the circumstances, and say, well, I've got to get out of bed now because I'm not sleepy. And the doctor said, I got to get out of bed now because I'm not sleeping. Well, we have some more tools later on that are going to try to make that easier. But still, this tool becomes critical for a sizable number of individuals who, when challenged, will say, okay, I'll try it. Keep in mind, you will have many individuals who can't try this. They will not get out of bed. They're not ready to do that. The bed is such a level of security, not just because of the rest component, but other deeper psychological aspects that really end up having to be dealt with through psychotherapy. In other words, a psychotherapist can actually work with the individual on this particular issue and help them begin to understand that, yes, maybe you can take a baby step and do something. Maybe you can sit up in bed. Okay, if you're not gonna get out of bed, maybe you can sit up in bed and do something for a few minutes and see if you get sleeping. If that doesn't work, well, maybe then you can get out of bed. So these are the 3 steps. They're a very big deal. They're a huge component of helping people understand sleep medicine. So much of sleep medicine is self-empowerment. You absolutely need to engage the individual so that they buy into it and want to attempt the steps because it makes sense. Now, this graph explains homeostatic sleep drive, sometimes called sleep pressure. It simply means what goes down, meaning the number of hours you sleep, that's the red line, must go up. There's actually a treatment now in the scientific literature, and some people are using it. I'm not recommending it here. I'm mentioning it to prove a point, where they take individuals with hardcore intractable insomnia. They bring them into a sleep lab, hook them up to EEG, and keep them awake for 24 to 48 straight hours. By which time you can imagine these people are now beginning to feel drowsy. They let them go to sleep. They wake them up after 20 minutes. They keep them awake for another 2 hours. All this time, the person is literally learning, I never experienced this before, or at least I don't remember it. So that's an evidence-based treatment that's now in use, and again, chronic cases down the road. But that proves the point that as people learn that the less sleep they get, hopefully they're able to recruit more sleepiness. That at least is a plus of losing out on sleep. Okay, so let's look at our group for a second. Now, a person who had normal sleep previously, in all likelihood, knew everything we just talked about. They were somebody who maybe they had a regular bedtime. But why did they have a regular bedtime? Because they knew that's when they got drowsy and sleepy. And in fact, they were so normal that when the clock hit 10:30, because that was their bedtime, they suddenly go, oh yeah, I'm sleepy. I mean, that's how powerful it would be in that normal sleeper. That means that individual, when you meet somebody like that and you're helping them, they're going to be able to remember all of that experience. You don't have to teach them that much. They're going to say, oh yeah, I know what drowsy is. And so you're telling me maybe during this time we need less sleep, and maybe I can learn to recruit my sleepiness at the right time. Okay, let's take the troubled sleepers in the middle, good to excellent sleep. Well, what happened? What happened to throw them off? Here's one that'll really throw you for a loop. This could be a person who's on CPAP. And the CPAP is not functioning properly to keep them asleep. And that's what their complaint is. All right, here's a wild one. If they are experiencing more anxiety, they can't tolerate the pressure they're on, and it needs to be lowered. Okay, you ready for the flip side? Anxiety and sleep fragmentation may worsen airway collapsibility, and now they need higher pressure. So which one is it? Which one would the CPAP patient need? Higher pressure or lower pressure? So this is actually mind-boggling to the CPAP patient and to the sleep doctor. And it takes a bit to sort this out. But that person may have been relying on CPAP for years and having a great response. All of a sudden, it's not working out. In the last category, the main point I want to get across is not so much a tip about sleep, but about the fact that if this sleep problem, in fact, which was already poor and is now getting even worse, this is a huge red flag that the complexity of their sleep disorders is so profound, so intense, so severe, that this is absolutely going to require the input of a sleep specialist to actually move things along and help this individual. Okay, to summarize, this is the first half of the slides. Teaching people the difference between sleepiness and tiredness. Learning that it's best to only try to sleep or let yourself sleep, we say, when you're sleepy. And of course, avoid the frozen mattress. The evidence, the caveats are, a lot of this is going to be more applicable months from now when certain cases become chronic, but that doesn't mean a lot of it cannot be applied now. It can be. But it can be in the face of what? Ongoing trauma, ongoing grief, and these, again, require personally tailored responses. Okay. Halfway through the slides. How and with what does the human mind occupy itself during waking hours? So in my clinical and research experience, I've used a system that I call TFI, thoughts, feelings, images. The picture in front of you is just a demonstration, like how does the mind work? What do people notice about the way their minds work? If we use some exaggerated or stereotypic ideas, we could say the people who are intellectuals, they're scholars, they're lawyers, maybe they think too much. Maybe they spend a lot of time thinking. At the second level, and this is not levels, by the way, this is just the second line. Maybe you have a nurse, a social worker, a massage therapist, and they resonate really very well with the emotional side of life and are very good at that. That's why they went into a healthcare profession. In the third example, you might imagine, obviously, an artist, somebody who's doing a lot of picturing in the mind's eye. So this system, I believe if you reflect on it, you will realize that everybody uses all of this stuff all the time, but each person has their own balance. Some people do like to spend more time in one area more than the other. And some people may like to avoid certain areas more than another. My experience is that a healthy balance where a person can access any of these places at any given time as needed usually represents a more healthy form of consciousness. But in the case of chronic insomnia, and we'll start there because we can't exactly say the identical things about what we're going through in these 3 months. Most insomniacs choose consciously or unconsciously to repress or suppress emotion. They love to think, which is why they often are so susceptible to the problem of racing thoughts or a racing mind at bedtime. They don't realize often that those racing thoughts are the residue from the day of unfinished business, some of which has to do with unfinished emotional business. But the bottom line is, for an insomniac, you're often dealing with this imagery system. You're often dealing with this thinking system because they're saying, can you help me stop my racing thoughts? To them, feelings may seem uncontrollable. The imagery system may be hit or miss. I found all three systems work to teach people how to cure their insomnia. And the two main strengths of the TFI system is the first one, it actually teaches us how we fall asleep. And the second one provides the three unique pathways in dealing with insomnia. So how do we fall asleep? Amongst this group, I am fairly certain that many people have had the experience of observing themselves fall asleep. They've actually observed in their mind that they are falling asleep. For them, this is not new information, but most people don't necessarily have that experience. They may have heard of it. You get into bed, you lie down, and you start to think. It's not a surprise. It's quiet. You're not talking to somebody else, presumably. You just have a certain quiet time. You were probably thinking before you got into bed. You got into bed, you're still thinking. In some people, if that thinking becomes very random quickly, that's a huge benefit because that person is going to go to sleep faster. If the thinking isn't random and it's more linear, as if one is thinking about a problem from yesterday or a problem that's going to happen tomorrow, or not even a problem. You'll be thinking about something that's just neutral or something that's, you're enthusiastic about. Either way, it eventually becomes too much thinking. But most people have some thoughts, and then the next thing that happens is they feel something, usually with their body. They feel a temperature change, like the sheets are cool, or they feel the pillow is comfortable. They actually notice this, and that's actually moved them away from thinking because now they're feeling something. And then finally, this is the normal sleeper. The normal sleeper has images come into their consciousness. Sometimes these are called dreamlets. Another name is hypnagogic imagery. And these images can be of all sorts. They can be like dreams. They can be designs. They can be geometric designs. They can be flashes of light. They can be literally anything. And a person who observes these three stages is actually lying there saying, oh yeah, I'm falling asleep right now. And that's the last thing that they remember because they fell asleep. So we want to replicate this in some way. Obviously, if we go back to the original discussion of sleepiness, that's going to help all of this. But we're talking now a bit more complexity, and we're saying, can we use each of these three systems to help people? So I start with imagery. I have helped more people with insomnia with this system than any other system. It's incredibly simple. Most people understand it. Most people are willing to try it. You have a major caveat, of course. What's in the mind's eye of the people in the state of Israel the last 3 months? Unfortunately, traumatic memories, daymares, flashbacks, nightmares, and so forth. And so personally tailored healthcare, you have to know whether somebody can manage this. But if somebody looks at this picture, or they have a picture book that they look at, or they do a 1,000-piece puzzle at their dining room table before they go to bed, they're engaging their imagery system. And remember, the imagery system was the last step. That means you're skipping over thinking, you're skipping over feeling, you're going directly to imagery. And many people will fall asleep if they embrace this model, which means to use the model, you have to access what their skill is. Simplest way. Tell me, right now, everybody should do this, please. Can you picture driving or walking from where you live to some familiar spot? Just take a moment and do that. Could be a restaurant, could be a park, could be anything. Just ask yourself, can you do that? Now, most people, when given that instruction, unless they're in group 3 and they have very unstable psychiatric distress, unstable sleep problems, they may not be able to do that. They may have a black screen by now because they have to block everything out. Or in the worst, not the worst case, but in another case, they could have intrusive images, as I've noted on the second item. If they say to you, if you say to them, do a longer imagery session, take more time in your mind's eye, and they say, oh, but this stuff is coming back to me. Now we have the potential for, no, this person can't do it. Unless you go to C and they say, I know how to acknowledge a troubling image, an unpleasant image, a disturbing image, and I know how to move back to pleasant imagery. If you have an individual like that, then imagery absolutely can be used as the first line treatment to help them go to sleep. If they can't do these 3 steps, then it's more important under the certain circumstances to say, well, I want to work with you to practice pleasant imagery so we can help you learn what to do when you have an unpleasant image and move you away from that. And that fits into various models of psychotherapy, exposure therapy, and so forth. And I would say, I would encourage people to do that specifically for the purpose of empowering the imagery system, the mind's eye. Again, to repeat, I have used this with so many people who never thought they had any solutions to sleep. People even on hypnotics who were not getting good responses. Very simple to describe. The first part is, this is how we fall asleep. You're jump-starting the process. Your imagery system is intact. Now practice. And one last pearl would be, some individuals, maybe many right now, if they're going to do this, you want them practicing the imagery in a session. You don't want to say, just go do this at home. Let them do it in a session and say to you, what was that like? What did you learn? What do you know about your mind's eye? Do you see that you have more control over it than you thought? Do you also see that there's a certain plasticity to it, that images, like you thought you were going to go to the park, but then suddenly you turn and you went to the movie theater? That's all part of normal daydreaming. If the person can, get back to that capacity, it's very helpful for the purpose of falling asleep. Okay. This is the toughest one. It's tough now. It'll be tough in 6 months. It'll be tough in a year. But the good news is, this is your strong points. This is where you all have learned a lot in your careers, some more than others. But seeking bedtime emotional closure during ongoing trauma seems like a non-starter, maybe even counterproductive. And so what do we mean then by emotional closure? Well, we certainly don't mean closure of trauma. We certainly don't mean closure of grief. That's insulting. That's obviously not what we're talking about. We're talking about it, is there a possibility at all of closure on the day? And we're even talking about shorter periods. Is there a possibility of closure on the last 12 hours? the last 8 hours so I can at least get a nap. So that's what closure is referring to. Now, there's a very simple example you can bring up to learn about a person's emotional processing skill, especially as it relates to sleep. You go, have you ever had that experience? You got into bed, started thinking, and you noticed that you didn't stop thinking. And then all of a sudden, you felt something in your body. You might have felt it in your throat, your chest, your hands, your shoulders. And you're thinking, I'm in mental health. I'm thinking, but I'm feeling something. And the next thing you know, you realize you're frustrated about something. And you put the thoughts and the frustration together and you go, oh yeah, I'm frustrated about that conversation I had 7 hours ago with my boss, my friend, my colleague, my spouse, with the sales clerk at the grocery store, whatever it was frustrating. And now as you, because you're trained, you work through the frustration, you go, I'm not just frustrated, I'm angry. I am angry, and I know that this is something that's really been bugging me. And that's why I've actually been thinking about it much of the afternoon and evening. And here I am in bed, wasting my time when I should be sleeping. Okay, what's my plan? I know what the problem is. I know that I'm angry. And I even know what I need to say to this individual the next time I see him. And I'm not talking about urgent matters. Like you might see him the next day, you might see him the next week, him, her, whatever. You're going to see this person, and it's like your closure is real. Like, I know how to deal with this. And what do? You go to sleep, because the sleepiness comes in right then because you just got closure. Now you can ask anybody this question and say, hey, have you had that experience before in your life? Do you remember doing that sometime? Doesn't even have to be while you're asleep, although it's better if they had it that way because it's more relevant to our discussion. But somebody might have had the experience like in follow-up from a psychotherapy session where they came and said, oh, that technique you taught me was great because I had this session and blah, 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 blah. And so now you're getting it. This person understands this point. However, you're going to have a whole bunch of people that process will not generate relief. It will just rile them up. And that riling up, that emotional tension, is letting you know that their emotional processing skill is really not at the level you hope you had gotten them to, or, maybe you're seeing them under different circumstances. The point is that technique won't work for them. They're not ready for that. They do not understand there is a way to get to closure. So if they are successful and they have done this in the past and they're willing to consider it, then obviously they could try it. But there's tremendous difficulty right now in what somebody could choose to process because there's too much to process. And that's why I say this is a very difficult, challenging thing to work on. It's very useful down the line. And it can be useful now if you think about it as a 6-hour window when somebody says, I need to nap. I just need to have that break. How do you select the right candidate for this? So it's a complex approach to insomnia, more suited to chronic cases. In some cases, you really want this individual doing exposure therapy before attempting it. As I've said before, a previously normal sleeper might already have this coping skill. That's why they're a normal sleeper, because everybody can have instances like I've described, and they end up with this experience. They resolve it, they go to sleep. Emotional closure in the long run means embracing the concept emotionally and spiritually that the day is done. When a person actually learns to say the day is done, most of the time they recruit sleepiness and they go to sleep. And I put in there the words emotionally and spiritually because in many religions, we know in Judaism, we have the bedtime Shema, but in Christianity and Islam, they have other prayers that people can say at bedtime, and these may be very powerful influences for people who are religiously minded. And if they have not used these prayer techniques, they may want to consider this as a very important instrument for helping them get to the place the day is done. Again, when bringing up the concept of emotional processing, I always want to bring up this point again, that losing sleep over losing sleep, which is that desperation you will see in the person obsessed with sleep, is having that problem, and they usually need medication. Okay, now the last in the TFI system, we did imagery, we did emotion, we did feelings and emotions, and now we do thinking. So thinking is a bit confusing because obviously you don't think you can think your way to sleeping, because you always think thinking is about self-talk and racing thoughts. But here we're talking about an intellectual strategy of cognitive behavioral therapy, where the hope is if we engage them in a rational discussion of how sleep works, maybe they will take actionable steps based on the insights that they have gained. So some examples would be when a person is going through these discussions from earlier in the slide set, and more information that might come up in the Q&A, the person may have the idea, well, could I be spending too much time awake in bed? And absolutely, that's what happens, especially in this situation. If people have not prepared themselves, and they can't prepare themselves for this kind of trauma or this kind of grief, it's natural to want to spend more time in bed, not less, for a lot of people, not everybody. But the individual who comes to the recognition, you know what? I'm spending too much time in bed. That's a huge insight. And that person will realize, I've got to get out of the bed. That's a big deal. Same concept as I don't need as many hours of sleep as before. And that's true. And maybe people have already begun helping patients learn that, but they might need to have it repeated. A reassuring thing is that when things do quiet down, God willing, that, you know, things do return to normal. People do have more normal routines, and sleep will return for many people back to their baseline. There's a technique in sleep and sometimes in psychotherapy called writing down a worry list. I am not a great fan of it. I just haven't used it, but I can see where, from a psychotherapeutic point of view, those of you who've had success using this technique, I encourage you to use it, especially if you are convinced that the individual did write down the worry list and it helped them to disengage because they said, well, that's for tomorrow. There's tremendous variability in the way cognitive behavioral therapy for insomnia is practiced, unfortunately. And that's why its track record in research is unbelievable. Its track record in clinical practice is incredibly variable and disappointing. I have seen far too many number of patients who've told me they've had CBTI. And when I listened to what they had, I said, okay, well, yeah, that's CBTI, but the instructions were not delivered in a personally tailored way. And let me give you the best example because it's a big one that always comes up in really hardcore, difficult cases. The individual is sleeping 4 hours a night per patient report. How much time are they spending in bed? 9 or 10 hours. You can't address that gap. In standard cognitive behavioral therapy of insomnia, you could literally have someone say to that individual, okay, well, you need to spend 5 hours in bed. Well, you're only getting 4 hours of sleep. You just spend 5 hours in bed. That's going to be very, very irritating, noxious, vexing to that patient. They won't do it. But what can you do? You can say, so 4 or 5 hours of sleep, 4 hours, 10 hours in bed. This next week, I'd like you to drop down to about, could you drop down to 9 hours and 15 minutes in bed, 9 hours and 30 minutes? Would that be possible? Person listens, sounds very reasonable, say, yeah, sure, I'll give that a try. More than 50% of the time, if you do that, that individual will come back 2 weeks later and say, you know, that idea was really good. I noticed when I shortened the time, it just felt like my sleep was a little bit more consolidated. So, you know what I did? I dropped my time in bed down to 8 hours and 45 minutes. And you go, oh, well, that's fantastic. Like now we're really moving in a good direction. And you can see over time, that person could literally get down to 7.5 hours in bed, 5.5 hours of sleep. And for them, that would be miraculous. And that's what they want. And that's what they need at that time. So that's why a personally tailored approach to CBTI is so crucial. Now, one more thing about thinking that I alluded to, there is a research protocol where you can teach an individual to use non-linear words. And so I'm going to give you 3 right now, like building, comic book, potato. So if I said to you, you know, when you go to sleep tonight, get into bed and say building, and then pause and go comic book, and then do potato, okay? Now you, the audience listening, you try to make up 3 words right now. See how quickly you can make up your 3 words in your own mind. It's hard because the words that come to your mind usually relate to each other. And so it's a good technique also for the patient to say, well, you can take these 3 words, but take 3 more words or take 6 more words and keep working on making up non-linear, you know, random words. That particular process has been studied in research and actually helps people. My speculation is whether if you make up a bunch of nouns, whether you could picture the nouns. Could you picture the building, the comic book, and the potato? Now you're getting the imagery component as well. Okay, we're getting close to the Q&A. So I want to bring up an important point. These are the things I haven't talked about. And I want to make sure we go over some of these again in the Q&A because most people have questions about them. But let me just give you some quick tips on them. Sleep hygiene is a very, very problematic strategy for use in helping people with sleep problems. The odd thing about sleep hygiene, it is a spectacularly useful technique when you've actually treated your sleep disorders. You treat your insomnia, your nightmares, your sleep apnea, your restless legs, whatever it happens to be. When you do that, and then you go back and look at your sleep hygiene, it'll have so much more impact than before. Now, are there mild cases where you say, darken the bedroom, get a cooler temperature in the bedroom, put in earplugs? Yeah, of course. But it's never usually ever worthwhile to start with that with a patient as if that's going to be the incisive strategy. Oh, and I'll see you in a couple of weeks. You always want to start with something like, talk to me about sleepy versus tired. Talk to me about how much time you're spending in bed. Sleep hygiene, think about it more in the background until you hear something bizarre like, yeah, I drink a lot of coffee at dinner, and yep, that's the problem. The next big one is hours of sleep. The model that we've developed over the last 30 years is a sleep quality model because you're going to learn over these sessions that sleep quality drives most sleep problems, not sleep quantity. But people do obsess about the number of hours because unfortunately the media in particular and many in healthcare think that talking about numbers of hours of sleep is relevant. It's largely irrelevant, except in certain circumstances. We happen to have a circumstance right now where it is relevant because people are losing too many hours of sleep. So we do have to consider it. A component of that is people who look at clocks and engage in time monitoring behavior. time monitoring behavior is second on the list of causes for exacerbation of insomnia. The top of the list is racing thoughts. Number 2 is clock watching and time monitoring behavior. So we can talk about that at length if you want to, because you have to gauge a certain way to help somebody stop time monitoring behavior. Napping and split sleep schedules may be the most important thing we have to talk about in the Q&A. I'm not sure, because people have to be able to get some additional sleep. And lots of people are developing bizarre sleep schedules for all kinds of reasons, and it's good to talk about that. Circadian rhythms, it's probably not something we can get into much, because circadian rhythms could be blown out of whack for so many people in this situation. And it's not like you're going to have some instrument to solve that problem. Now, getting back into simple things that are very relevant: white noise, the sound of rain, the sound of music. Absolutely, do you want people to use these techniques if they can make it work for them? If somebody says it works, do it. There's no question. You can get the sound of rain on every phone nowadays, and there's no question people can use that and it will work. And then last, and certainly not least, is what is the role of caffeine and stimulants in helping people get through the day, because that is needed for a whole bunch of people. And then what's that going to do to their sleep at night? Okay, finishing up. Sleep interventions are nothing to sleep on, but we always want to take into account these 3 groups with the caveats. And if, you know, in our Q&A, it's fine to bring up a certain type of patient that would be in any of these groups. Now, here's the last slide on confidence. I have a very, very long history of working with mental health patients with sleep disorders. That means that in my career with research, in lecturing, in teaching, workshops, seminars, whatever you can think of how you would disseminate this information, I have worked with, it's probably close to 1,000 people by now. And the deal is that if you take what you've learned in this session and you apply it to either yourself or to a friend or to a family member, and you get this part going right away where it's making sense to you and you see it working, that's going to resonate with you and it's going to resonate with your patients. The confidence builds and you realize, I've got a whole new set of tools in my toolbox that I can pull out every single time I've got to deal with sleep issues. I do not have to refer somebody to a sleep specialist. I've got here the beginning of a very important set of tools. And then if that happens, you will see often rapid improvements in sleep. When you see rapid improvements in sleep, you're going to witness a decrease in psychiatric distress symptoms, PTSD, depression, anxiety. And it's going to be very obvious. And when that happens, that means that psychotherapy that you want to do is going to now be even easier. And it's going to be even more potent. And it means you actually have more flexibility and more opportunity to adjust medications. So it's a very exciting time when you see this. But you have to do it and feel very confident that it's working. And the best place is to start with yourself if you've got the sleep problems, and with family and friends. And that will go to Q&A. That's the cover of my book. Thank you very much.
Thank you, Barry. Thank you very much for a very educational talk and very practical. And it seems that you have so much experience, so many pearls of wisdom in this topic that we could go on forever, but we do have to go to sleep. And we should set a model for our patients as well. First of all, many thanks in the chat and in the WhatsApp chat. So thank you about that. Is it okay if we start with 3 questions that we collected, and then maybe people would like to raise their hands and maybe ask you directly. But first of all, you explained to us about the definition of sleepiness versus tiredness, but how do you say that? How do you talk to your
Great.
patients about that?
Great. I'm sorry that I overlooked that. So when you're sleepy, it was the time that you were in synagogue listening to your rabbi, or in church listening to your pastor, or you were at a movie theater at a boring movie, or in a lecture hall listening to a lecture, and what happened? Your eyes got heavy, you got the feeling of drowsy, and sleepiness is in here. This is the only place you can experience sleepiness. It is your mind doing this thing telling you, I want to sleep, and you're sleepy. Tiredness is a body experience. It is something you feel in your body as fatigue, but if nobody has ever explained to you the difference, you could think the two are the same thing. Great question.
Yeah. Second of all, maybe it's a wide topic, but what is your standpoint about weed, cannabis use for sleep disorders, nightmares? In Israel, we don't prescribe what we give a license for medicinal cannabis for PTSD and sleep disorders.
Right. So we're in a period of time of experimentation where people are going to use things like they're going to use melatonin. And what we know is that melatonin may work for some people, but we do know from research that extended melatonin is the one that's likely to actually work. It's actually been researched and proven to work. With CBD, I have no experience. I've read a little about it to know that there are dangers that it probably may aggravate sleep fragmentation. On the other hand, there are people who probably are using it and say that it benefits. So I don't say to them, you can't use it. I say, okay, well, this is your personally tailored approach. And down the line, maybe there's a better system, but right now, maybe it's appropriate.
Right. And the third question that I got, what about children and adolescents? Would you apply the same techniques to work with those segments of population?
Absolutely. Virtually everything we described can be used with children, adolescents, young adults. When we get to IRT next week, children are the easiest group to deal with in using IRT. They have a natural affinity for the imagination. But all the other ideas about sleepiness, a child can learn, oh yeah, I'm not drowsy. I'm wired. I'm scared. I'm nervous. And the question is, when you're trying to get them to relax, you want to be able to say the word. Yes, you want to do this breathing exercise and maybe you'll relax. But no, you want to be incisive and say, you're not just trying to relax, you're trying to get sleepy. Here are some tools. You can do this 1,000-piece puzzle on the dining room table. It absolutely is a very useful tool to get a family working on a puzzle, because a puzzle requires you to think about the sizes, the shapes, and the colors, and you really can't keep thinking, and it starts your imagination going.
Thank you.
So Dr. Lurie, you'll select the people who want to ask a question, and then, okay.
If there is anyone who wants to raise a question, this is the time, or be at peace forever.
There are a couple of questions in the chat, by the way, and other questions. They're in English, so I can read them.
What about if one falls asleep easily but wakes up every time fully energized after 4 hours, ready to do anything, but is still exhausted in the middle of the day during the working hours?
So that's a great question, because that's probably a common problem. It's also a common problem October 7th, because that's one of the most common things insomniacs will say. Most insomniacs over time stop having the problem, especially after the age of 40, stop having the problem of difficulty falling asleep at night. They are so wiped out, they get into bed, they pass out, and they sleep for 2, 3, and 4 hours. But then they wake up, and they wake up wide awake. The question I'll tease you with is, why would they wake up wide awake? That's completely illogical. If you have all of this sleepiness in your body, all this sleep pressure, there's got to be something that's waking you up and putting you in a sympathetic or adrenergic state. And so most people, even people who have the problem of waking up wide awake, have also had the experience of waking up and rolling over and go back to sleep. So until we can get to that problem of why you wake up this way, right now we have to focus on what can you do to go back to sleep then at 4 o'clock. And the answer might be, if I take at face value the question, the answer might be nothing. The answer might be get up, accept the 4 hours, and go about your routine as best you can, and then pick the judicious time, God willing, during the day that you can nap. And even if that's going to screw up the nighttime sleep, I don't care, because the sleepiness can be so intense after getting only 4 hours of sleep. You're not a safe driver. You're not good at making certain decisions. Now, there's some people who are just going to use caffeine and stimulants, get through the whole day, and they're going to do 4 hours the next night. But that may be in their job description, and maybe that's what it's going to be. But for some individuals who can get that break and take that nap, and let me just throw this in now about napping so we're clear. Napping is so unbelievably potent. You can learn napping techniques where you can nap 60 seconds and be able to be awake for 2 to 3 hours with fairly good energy. You could take a nap of 1 hour and feel rotten for the next 5 hours. So it's very judicious. You really have to figure out the napping that's going to work for you. And it takes experimentation for virtually everybody to get the best out of a nap. But I do encourage napping during this type of exposure we're dealing with.
Sorry, there's a common notion that napping is not the same as nighttime sleeping. That is a different architecture and different brain function that goes on there, and it's not equivalent and cannot be replaced. What do you think about that? What's the literature say?
I would say that that's largely either not relevant or not accurate, because when a person has only gotten 4 hours of sleep or 2 hours of sleep, they actually could take a nap and go into the deepest stages of sleep. They could also start dreaming. And so those are all the stages of sleep you get at night. So no, the sleep can be very, very valuable. And how you get into those stages is tricky because it depends on what else is going on in your sleep. One thing we haven't talked about yet, but again, I'll tease you with it. If you haven't heard of the glymphatic system, the brain has its own natural brain washing system. This system is cleaning out the toxins in your brain while you're sleeping. And that's one of the reasons why when you wake up, you feel better, because you have been restored. You have been healed by this sleep. It is all but possible that during a nap, that same system is activated, because that system is known to be activated more when you're sleeping than when you're awake.
Do you question, and then someone would want to ask
I want a question from the cat.
Yeah, but do you use on a daily routine work objective measurements such as sleep lab, actigraph, or do you just rely on the subjective reports of the patient?
I rely on the subjective reports for to be able to discern which pathway we need to start with. So I'm a mind-body medicine person. Let me make it abundantly clear. There is no such thing as a sleep disorder that is strictly psychological. I do not believe there is such a thing. There is no entity that's strictly psychological. That doesn't mean there are some sleep disorders that are predominantly psychological, but there's always something physiological that is going on in your sleep. So it's mind body. And that's what we get to in the third session. We talk about sleep fragmentation. So if you ask me, do I use the sleep lab? Religiously is the answer. We want to do sleep testing in most patients, but we don't necessarily do it right away. All depends on how they present, how we can help them quickly. And we actually did a bit of an experiment on this 20 years ago at our sleep center, where we specialized with mental health patients who were coming to us largely because they had intractable sleep problems. We gave them the choice. Would you like to start with a conversation with me, the sleep doctor, or would you like to start in the sleep lab? 90% chose the sleep lab. So people who are mental health patients with chronic sleep disorders are starting to get wind of the fact there's something physical going on. And they've actually been trying to tell the doctors that for decades. When I was in training in sleep medicine in the 1990s, they actually had the paradigm that if a person came to me and said, "Doctor, if I could sleep better, my depression would be better." And I was actually trained to believe that meant the patient was depressed. That was the depression talking to me. And I only took a few more years to learn, no, the patient was right. The patient had much more going on with their sleep. And when the mind-body approaches to sleep were addressed, that patient's depression improved. I'm not saying it went away, but it improved because the patient was right. The patient knew there was something else going on.
Okay. Rebecca, would you like to ask your question? You raised your hand.
Yes, thank you. I wanted to know in terms of fibromyalgia, people who are suffering from fibromyalgia, and often it's not even the pains, it's really the sleep that bothers them the most.
Right.
What do you have to say with that?
So there's been a lot of research on fibromyalgia and sleep, and it's all mostly 20, 25 years old. It's very conclusive. Those of us in the field who've been a part of it and have seen it, and the leader is Dr. Avram Gold in New York. He did the study that showed that a consecutive series of fibromyalgia patients have a unique sleep disordered breathing condition called upper airway resistance syndrome, otherwise known as UARS. And here's the interesting thing. He got all of them to try CPAP. And every person who tried the CPAP said that it improved some, not necessarily all, but some, in some cases cured their fibromyalgia. But many of the individuals stopped using the CPAP. They couldn't tolerate it. Over the years, we learned to use other kinds of PAP therapy. In fact, we stopped using CPAP in 2005 for just that reason, that mental health patients can't really tolerate CPAP. And we'll get into that in depth in session 3. So yes, there's a very strong link. There's also the possibility of restless legs and leg jerks. Whenever I see a fibromyalgia patient, I always encourage them to get sleep testing.
Thank you. We have a lot of questions. A question here. What do you do with patients who tell you that their sleep is very light? They sleep and then they wake up with every stimuli, every little thing. What would you advise those patients?
It's a great question. We see it all the time. And of course, we've got the pre-October 7th and the post-October 7th. So currently, it would not be surprising to have many people tell you they have light sleep. And there's not necessarily much you can do about that right now, or certainly in this session. There'll be things you can do about it in the third session. Nonetheless, when you treat somebody's insomnia, there is some evidence that you can deepen sleep. So for example, best example, if you say to somebody, you're spending 7 hours in bed, but you're only getting 4 hours of sleep, would you consider going down to 6 hours in bed and getting 4.5 or 5 hours of sleep? That person may come back and say, oh, my sleep is actually deeper. It is more consolidated, and now it won't be as light. However, pre-October 7, if you think about the third category we talked about, the people with the troubled sleep that were not doing well, many of those people do report light sleep. That is, in fact, how many of them ended up on being put on sedatives and or other psychotropic medications to allegedly deepen the sleep. But the real question is, why was it light? And here's the jackpot answer. In normal sleep, there's absolutely no such thing as light sleep. There's no such thing. You can have some lighter stages of sleep, for sure. But there's no such thing as a person. Now, I take it back. There are rare exceptions of a person who may be born with an odd condition of insomnia that is thought to be biological, a different kind of brain. Extremely rare. I'm not talking about fatal familial insomnia. I'm just talking about some people. They maybe need less sleep, whatever it is. The average person who says they're a light sleeper will say, I've always been that way, or I noticed it started when I was a kid. That person has a sleep disorder. There's something physically wrong with their sleep that they don't know about, and that is causing the experience of light sleep for the simple reason they never go into delta sleep. Or they're so sensitive to anxiety that even if they're in delta or other stages of sleep, this irritation during the night corrupts that form of sleep, and so it's just light to them. So it's a big red flag for sleep testing when somebody complains about light sleep.
Thank you. People are asking about exercise and sports. What do you think about the positive and negative effects of exercising and the timing during the day? I guess it is related to conditioning, what people are used to do.
Here's a great example of where sleep hygiene doesn't work. If you've got somebody with significant, moderate to severe sleep problems, and you have determined, and this is a key point in mental health and sleep that has to be, it's the Venn diagram. When we think of impairment in sleep, we think about people who make mistakes, who get injured, who can't drive safe. And so whenever I'm talking to a new sleep patient, I'm talking about walking. You walk. Because if they have a serious condition that I'm concerned about with their sleep, they're impaired. And so the notion I'm going to say, yeah, go out and run, go out and lift weights. I personally believe, depending upon the age group, depending upon their past history, I'm very concerned about their risk for injury. Now, if you're talking about young people and they have a certain lifestyle, absolutely, they can use some of these tools because some exercise will deepen sleep. But when you talk about people who have the more moderate, severe conditions, they are clearly impaired, both from a psychiatric, psychological point of view. They're impaired because of sleep. They're absolutely at risk for injury. And I encourage them to walk, walk, and walk. That's the only exercise I recommend.
I'm not sure, but maybe we will discuss that later on in the next sessions. But what do you do with people who avoid sleep because of the nightmares and with the sense of, they need to be alert right now?
Very big problem. Very big problem. And yes, next week there'll be possibly some answers. If there's medications, there's the drug that's not available in Israel right now, Prazosin. And there's a question about whether there might be some substitutes. Certainly those should be considered. There's always been the theory that if you could give somebody a strong REM suppressant medication, maybe you would get some decrease in the nightmares. The problem is with the post-traumatic stress process, people can dream all over the place. It doesn't have to be just REM sleep. So there's not really a good answer to that. You could argue that an individual might say, I'll sleep 90 minutes, set my alarm to wake up before I go into REM, and I'm going to get up and I'm going to work for a while, and then I'm going to try to go back to sleep and get a few more hours. You could always try something like that. I don't have high expectations it's going to work. These individuals often end up with stimulant medication during the daytime to be able to function, or whether it's caffeine or stimulants. The notion of treatment of acute nightmares is something we will get into next week, because there's only been one study ever done that I know of. I did it with a colleague who was serving in the military in Iraq about 15 years ago. He tried IRT on 11 soldiers, all who'd been exposed, to trauma from an IED. He did the therapy within just a few weeks, which makes it very acute. And about 7 out of the 11 had an improvement. The problem that we'll discuss next week at length is who is really appropriate to give IRT to, because there's certain conditions that make it the wrong treatment, and there's certain conditions that make it, potentially very palatable.
We'll take two more questions. One in the chat, someone asked, is there anything specifically to assess the sleep quality beside the sleep lab?
Absolutely. There are so many things you can ask about. And just to tease you, I'll just throw out a whole bunch right now. Did you know that trips to the bathroom at night is not normal? I want to see the shocked faces. You should not be waking up at night to pee. Huge red flag where something might be going on in your sleep. You should not be waking up in the morning with headaches. You should not be waking up at any time, morning or during the night, with a dry mouth. You should not be tossing and turning in your sleep. If you put a pair of socks or a t-shirt at the end of your bed when you go to sleep, when you wake up in the morning, it should still be there. If it's not, that's a red flag that something is going on in the quality of your sleep. Here's another good one. If you suffer from high blood pressure, the diagnosis of hypertension, and you're on blood pressure medication, there's a huge chance, there's something going on with the quality of your sleep. If you have cardiac issues, there's a huge chance, arrhythmias, heart attacks, strokes, a huge chance something is wrong with the quality of your sleep. And I'm not just talking about oxygenation. I'm talking about sleep fragmentation, which we'll get into in the third session. Is that enough? You want more?
Anything to induce sleepiness, to improve the sleepiness that you know of?
Well, I mean, it's a tough question because, if you're talking about pre-October 7, you would say to the individual who's, willing to take the challenge of, are you willing to restrict the amount of time that you sleep? The fastest way to actually increase your sleepiness for your next sleep period is to agree you'll sleep less. But that's a very difficult thing to do in this situation because you're already sleeping less. And you're looking for some window of opportunity for the judicious napping so that you end up being able to say, well, I feel refreshed. I can get back in the game. I can work and function well again. So I don't think there's a good answer to that question at this time point.
Right.
Three months out.
Dr. Roy Gilad, who works in Canada, wanted to ask something. Roy? In sleep?
Do I see the person, or is it on a different screen?
He should be here, but he just went away. So I'm
Okay.
sorry. Anyway, really, thank you very much, Dr. Krakow. I think we all learned so much from you tonight, and it's so heartwarming for us that you help us in this specific time, very difficult times. So I'll just say thank you and maybe good night. Sleep well.
Maybe just a word about next week.
Next
Sure.
week, yeah.
Next week, we do 1:30 to 3 again, my time, and 8:30 to 10 your time. And it's going to be all devoted to the treatment of nightmares with a lot of focus on imagery rehearsal therapy.
Thank you very much, really, from the bottom of our hearts. Have a good night. Have a rest of the night.
Ido, Aviv, Lior, do you want to spend a minute afterwards just to talk for a minute?
Sure.
Okay.
Sure. Thank you very much.
Thank you all.